Hello everyone, I'm Professor Dong-Seok Sohn at Catholic University Medical Center of Daegu. Unfortunately, I'm sorry I cannot meet you personally today because of a COVID pandemic. I hope that all of you here are able to overcome COVID crisis well and stay healthy. 3D ridge augmentation for implant placement is considered as one of the most challenging surgery in implant dentistry. That is why many dentists are afraid of performing vertical augmentation. Today I'm very pleased to give a lecture on the topic of a simplified three-dimensional ridge augmentation using tenting abutment. This innovative surgical approach has the advantage that more oral implantologists can easily perform vertical ridge augmentation. Space maintenance with bone graft during healing period is considered the most critical factor for successful 3D ridge augmentation. How can we maintain the volume of bone graft during healing period? Various surgical techniques have been introduced to get favorable space maintenance in ridge augmentation. Among many methods, in order to get solid immobilization of bone graft for advanced ridge augmentation, autogenous block bone graft was often necessary prior to or at the time of implant placement. In old school method, as shown on this slide. This is Lemus bone graft, this is chin bone harvesting, this is grafting of autogenous chin bone for ridge augmentation. I used to be a big fan of auto block bone for augmentation of a huge defect, as shown on my report, which was published in IJPRD 2007. This patient referred to me for 3D ridge augmentation after extraction of hopeless upper anterior 3 unit bridge. A full thickness flap was elevated to expose bony defect. Huge 3D defect was revealed. Piezo surgery was used to harvest the chin block bone. Unlike osteotomy using microsaw, piezo surgery produced a highly controlled and clean osteotomy as shown in this slide. Each block bone was fixed with a 2-point fixation with micro screws. Orthobone chip harvested from chin was grafted on the residual defect. A collagen barrier was not used in this case. 2 midi implants were placed at the same time on the palatal bone in order to deliver immediate temporary restoration. This is post-op. This is 1 month healing. Bone graft site was exposed again after 6 months healing in order to evaluate ridge augmentation. Favorable 3D ridge augmentation was achieved in this case, and 3 implants were placed at the same time, and immediate restoration was delivered. This is before extraction. This is after the delivery of final implant spotted restoration. This is 13 years loading, showing stable marginal bone around dental implants. This is pre-op. This is X-ray at the delivery of final restoration. This is a 16 years loading. Very minor bone resorption is observed. From the doctor's point of view, the result of the case just shown previously were satisfactory, but this patient complained lots of discomfort during and after augmentation surgery. This slide shows you complications and disadvantages related with grafting orthoblock bone. From patient point of view, they are not easy to accept patient morbidity and long edentulous period. Another more serious drawback of orthoblock bone in vertical augmentation is unpredictable resorption over time. According to literatures, intraoral block bone revealed about 17% of resorption after 4 to 6 months of bone graft. And iliac bone showed about 42% in anterior maxilla and 55% resorption in posterior mandible over time. Graft infection and failure can spoil a good relationship between patient and doctors. This complication causes patient discomfort and pain for a long time, as shown in this case. She was referred to me after failure of GVR at other clinic. All implants were removed on the day she visited me. CT scan shows you severe 3D defect on anterior maxilla. After 2 months healing of soft tissue, bony defect was exposed in order to do 3D ridge augmentation using chin block bone. Chin block was stabilized on the defect. Now I could get a 6 mm vertical gain. Particulate orthobone was grafted on the gap between alveolar bone and block bone. These particulate bone grafts were stabilized with fibrin sealant. I thought I got perfect tangent-free shoots, but block bone was exposed after 6 months, after 6-week healing. I was very embarrassed to see this result. A flap was elevated. Now the pus was discharged on the graft side. I was very embarrassed to see failure of chin block, and she was also very disappointed with this result. Second bone graft was done immediately after curettage of inflammatory tissue in the recipient side in order to maintain the volume of particulate bone graft vertically during healing period. 2 mini implants were placed as tenting pole screws. Allograft mixed with tetracycline was grafted and carved with a collagen barrier. Membrane tacks were not placed to stabilize the collagen barrier. Releasing incisions were made on periosteum and buccal mucosa of buccal flap, and FGG was done at the same time. Cyanoacrylate was applied to stabilize pregingival graft. This is 2-week healing. You can see it, small expose of collagen barrier membrane. Unlike the healing in exposed black bone, the healing in exposed collagen barrier was favorable. Simple technique utilizing GBR and tenting pole screw was performed, but the graft site showed favorable 3D ridge augmentation after 4 months healing. From this case, I learned a lesson that black bone graft is not only solution for three-dimensional ridge augmentation. This is real in function, showing stable gingival architecture around implant restoration. This is 11 years loading, showing stable marginal bone around implant restorations. What will be the result if implants are placed simultaneously in the atrophic alveolar bone instead of placing tenting pole screws as shown on previous case? Can we achieve predictable outcomes when implants are placed as tenting pole screws in alveolar bone and tenting pole abutments are placed on the platform of implants for space maintenance in 3D ridge augmentation? Let's look at this case together. This X-ray shows severe vertical deficiency on posterior mandible. Instead of placing tenting pole screw, 3 implants were placed at the same time. About 5 mm vertical defect is seen. All implants were exposed intentionally for 3 to 6 mm high. Good initial stability was achieved in all implants thanks to under preparation. Tenting pole abutment called Santa was connected to implant platform to maintain bone graft 3-dimensionally during healing period. Sticky bovine bone was grafted on the defect. This is X-ray after 3 months healing. Uncovering was done after 3 months healing. You can see well-maintained grafting materials over implant platform. So temporary restoration was delivered after 3 months healing. This is the X-ray after delivery of temporary restoration. To provide attached keratinated gingiva around implant restoration, sutureless FGG was done. Stabilization of FGG using suture is technically difficult, and the longest part I need to spend time. In order to reduce the surgical time, cyanoacrylate was applied along upper, medial, and distal edge of FGG. It helps to stabilize pregingival graft simply. I have done this technique for 2 decades with good result. Take a close look at the well-made pregingiva around implant restoration. This slide shows you serial periapical radiogram. This is periapical X-ray after surgery. This yellow line indicates original alveolar crest. This is a 3 months healing. This is X-ray after delivery, temporary restoration after 3 months healing. This is 1 year loading. The stable marginal bone is observed after 1 year loading. This slide shows you newly developed tenting pole abutment called SANTA. SANTA stands for Sohn's augmentation new tenting abutment. SANTA has shallow and straight neck to allow more bone graft over implant platform. SANTA 1 has 1 mm high neck for performing easy horizontal augmentation, and SANTA 2 has 2 mm high neck for performing simplified 3D ridge augmentation. SANTA 1 is indicated in horizontal ridge augmentation. Implants is placed 1 mm deep to alveolar crest, and SANTA 1 is placed on the platform of implants. 6 mm wide SANTA protects bone graft from soft tissue pressure during healing period, keeping bone graft material stable in the defect. Let me show you a case using SANTA 1 for horizontal ridge augmentation. This patient referred to me for the augmentation of a severe horizontal defect. However, I decided to do minimally invasive and simple ridge augmentation using SANTA in this case. An implant was placed in the ideal position, which is 2 mm deep to the proximal alveolar bone. The initial stability of implants was very good, as shown on this slide. SANTA 1 was connected on the platform of implants to contain grafting materials around implant necks. Sticky conditioned bone graft was grafted on the defect. Overgrafting should be done in this case. Collagen barrier membrane was not used in this case. 2 CGF membranes were placed on the bone graft in order to accelerate wound healing. This is post-op X-ray. This is preoperative intraoral view showing severe horizontal defect. This is the intraoral view after 11 weeks healing. You can see favorable horizontal ridge augmentation. This is the radiogram after 11-week healing. This slide shows you serial CBCT scan images. This is pre-op CBCT images showing severe horizontal defect. This is post-op CBCT scans. The bone graft is seen along exposed implant surface and under the SANTA. This is 11-week healing. Now you can see the maturation of a grafting material along implant body and under the SANTA. You can see well stabilized grafting materials under the SANTA in these images. This is intraoral image before placing bone graft materials. This is intraoral image after uncovering. Bovine bone particles are still seen. A temporary restoration was delivered on the uncovering day. This is a preoperative intraoral image showing severe horizontal defect. This is an intraoral image showing aesthetically restored alveolar ridge in 1 year loading. As you can see, in this case, severe horizontal bone reduction without using complicated surgical method can be managed simply by using Santa and sticky bone. Santa 2 is indicated for vertical ridge augmentation. Surgical procedure using Santa 2 is very simple. Implants are placed 2 mm deep to proximal alveolar crest, and Santa is connected on the implant platform. Sticky bone is grafted slightly over the top of Santa 2 in the bony defect, and tension-free primary close is done. Let's look at the case showing severe 3D defect on tooth number 47 and horizontal deficiency on tooth number 46. A full thickness flap was elevated in order to bony defect. Take a closer look at the huge vertical defect on the side of second molar and horizontal defect on the side of first molar. Autobone chip maker was used not only to collect autogenous bone chip, but also to do decortication at the same time. After doing under-osteotomy on the side of second molar, a 6 mm wide implant was placed with good stability. Santa 2 was placed on the implant platform in order to do simple vertical ridge augmentation. 4.5 mm wide Biotem implant was placed on the side of first molar, and Santa 1 was connected on the implant platform. Layered bone grafting was done in this case. Autogenous bone, sticky autogenous bone was grafted as the first layer in the second molar side, and sticky porcine bone was grafted to augment 3D defect as a second layer. It is also good to use 100% xenograft in this case. A resolvable collagen barrier was carved over the sticky bone graft not only to prevent the movement of bone graft material but also to block soft tissue ingrowth during healing period. As long as the sticky bone is utilized, membrane tags or membrane stabilization suits, which requires long surgical time, is not necessary. Santa has many advantages in huge ridge augmentation. It prevents collapse of bone graft during healing period. It maintains the volume of bone graft during healing period. Bone augmentation becomes simpler and less invasive compared to other complicated augmentation techniques such as a mesh or block bone or bone plate technique. Santa technique reduces the number of surgery and healing period. because implants are placed at the same time. I'd like to show you a surgical video of a simplified 3-dimensional ridge augmentation using Biotem implants and Santa. This patient presented with a severe vertical defect on right posterior mandible. Crystal incision was made with a 15C blade. Anterior vertical releasing incision was made beyond the mucogingival junction. Posterior vertical releasing incision was also made in order to elevate a full thickness buccal flap and lingual flap. Lingual flap is released with the pedestal elevator bluntly. Before placing bone graft material, the lingual flap should be elevated at least 10 mm high. Take a look at released dissected lingual periosteum and mylohyoid muscle. A sharp dissection to buccal periosteum was done. Before placing grafting material, buccal flap should be overlapped over the lingual flap at least 10 mm. 10 mm wide bone pen was used to prepare implant site in first molar, and 9 mm wide bone pen was used in second molar. The bone pins were placed to check occlusion and parallelism. Implant drills were used to prepare implant site. The under-osteotomy is usually recommended in order to get good stability of implant in the atrophic ridge. The final position of implant platform is 1 or 2 mm deep to the proximal alveolar crest. Orthobone chip maker was used not only to collect autogenous bone chip but also to do decortication. ACM is easy to collect autogenous bone chip. Wide body implants were placed. These are 5 mm wide and 10 mm high Biotem implants. Thanks to under-osteotomy, initial stability of implants were very good. Take a closer look at about 6 mm vertical defect interproximally. In order to do easy vertical ridge augmentation, Santa 2 was placed on each implant. Santa 2 has a 2 mm high neck. Autogenous bone chip harvested with the ACM was grafted, and sticky porcine bone was grafted all over the tooth bone. And collagen barrier was placed over the bone graft. Bone text or membrane text or membrane stabilization shoots is not required when you use sticky bone for ridge augmentation. You can save surgical time as long as you use sticky bone for ridge augmentation. A collagen barrier was folded to adapt on the bone graft. Before suturing, please make sure to get 2 mm overlapping of buccal flap over the lingual flap. Two horizontal matrix shoots were used to get soft tissue closed. After doing matrix shoots, the tissue approximation should be evaluated. Interrupted shoots or continuous interlocking shoots is used to finish soft tissue close. In this case, the continuous interlocking shoot was used. This is post-op X-ray. This is post-op cone-beam CT scan images showing huge augmentation. This is post-op panoramic X-ray. This slide shows you serial X-rays of this case. This preoperative X-ray shows you severe vertical defect. This is post-op X-ray. This is X-ray after 5 months healing. This X-ray shows the favorably augmented alveolar ridge. This X-ray is taken after 3 months loading of final restoration. It can be seen that alveolar bone augmentation is stable. This slide shows you various surgical methods I have used for vertical augmentation. I used to use these techniques because of surgical invasiveness and long edentulous period and increased number of surgery. This is my conclusion. I have performed tenting for abutments assisted ridge augmentation for last 2 decades, and the results are very predictable. Sticky bone and Santa plays an important role for stabilization of bone graft granules and maintenance of the volume of bone graft placed on the defect during healing and loading period. Patient-oriented minimally invasive augmentation should be considered before considering other complicated and invasive surgery. Thank you very much for your kind attention.